Good afternoon and welcome. Thank you all so much for taking time out of your day to join us for this important discussion. My name is Courtney Murphy, and I serve as the President of Markets for Commonwealth Care Alliance. Our team at CCA is thrilled to partner with the Boston Globe to host today's event, and we're eager to get started. Before we do that and introduce our speakers, I'll just take a moment to provide a little background on who we are and why we're hosting this event today. CCA is a national multi-state healthcare organization with proven expertise in complex care coordination and delivery. We're mission-based, person-centered, and singularly focused on sustainable and evidence-based healthcare breakthroughs that fill important gaps in care and improve the health and well-being of people with significant needs. This includes advocating for affordable, high-quality, and cost-effective healthcare policies that lead to healthcare equity for individuals who need it most. In supporting our mission of doing this work, in our validated care model, we brought that to Rhode Island starting in 2021. From the onset, our decision to expand to Rhode Island was on our commitment to do it the right way. Healthcare challenges we've seen in decades of experience at our organization are the same issues impacting Rhode Islanders, and we know that we can make a difference with our care model for those in Rhode Island. Over the last 2 years, we've built our local team in Rhode Island, meeting with leaders in every corner of the healthcare and public health sectors. And we've also supported nonprofit organizations that we believe are making a difference. Most importantly, we've made a conscious effort to listen and to be engaged in the important conversations that are happening across the state. And that's what we're hoping to do with today's event. Thank you again for joining us. And please welcome Corey McCarty, CCA's General Manager for Rhode Island, who will be moderating this afternoon's discussion.
Good afternoon, everyone. It's Corey McCarty, and I'm the General Manager for CCA Rhode Island. And we're here today to talk about improving equity in healthcare in Rhode Island. I'm excited to welcome 3 panelists who are kind enough to join us today. Carrie Bridges Felice is the Vice President of Community Health and Equity for Lifespan. Dr. Amy Nunn is the Executive Director of the Rhode Island Public Health Institute and also serves as a Professor of Behavioral and Social Sciences at the Brown University School of Public Health. And finally, Dr. Robert Macarthur is the Chief Medical Officer for our team at Commonwealth Care Alliance. Carrie, Amy, Rob, we're privileged to have you all here. Thank you for joining us. We only have an hour today, and I know we're not going to solve all of the issues, but I want to at least give it a try. And so let's give it our best shot today. Carrie, I wanted to start with you. And as a well-respected professional that's been in this space for the better part of your career, can you lay the groundwork for us? What in Rhode Island is the most pressing gaps that you're seeing when it comes to equity in healthcare and public health?
Well, Corey, thank you. And I want to thank the Boston Globe and Commonwealth Care Alliance for putting on this event and inviting me to participate. It is, excuse me, my pleasure to be with you and to be with everyone today. And to your question, to dive in, the most pressing gaps. Listen, I'm going to pretend that I'm giving a short answer when in fact it's a big, long answer. But issues of equitable access to services and supports persist. So access to, for instance, healthy foods, access to behavioral health care services, those are real and they are persistent. In addition, though, we have gaps in equitable access to health promoting conditions. So, the conditions where folks live, learn, work, play, pray, like safe and healthy housing, those persist. And we can't ignore the impact of inequitable operations of systems. We're speaking about healthcare today. This applies in healthcare as well as other systems, the pattern of inequitable operations in terms of hiring decisions and purchasing, investments back in local communities, access to individuals having access to take advantage of the benefits of those systems. Those are also inequities. So it's the inequities that individuals experience in their day-to-day lives. It's the inequities that all of us experience in the settings in which we live, learn, work, play, but also inequities in how our systems operate and how they advantage or disadvantage groups of people. So not surprisingly, there's no, easy, short, 1, 2, 3 punch list of things to fix here. But it is also not insurmountable. And the inequities that we see that are significant still are addressable. And I think we'll talk about some of that in this conversation today.
Those are all really good points. And you were recently quoted in the Boston Globe with a great response as to where we are right now when it comes to equity in healthcare. And paraphrasing you, you said something along the lines of, it's great that we're at least at the point of asking, is it a problem? And you were talking about your own organization in that response. And so kind of building off of that response and what you were quoted on, has the rest of the state's healthcare community gotten to the point, or is it still a lot of work to be done educating leaders that this is still a real problem that exists?
I do think that the broader community and leadership in the broader community is also at the point of acknowledging inequities in healthcare and inequities in health. Excuse me. But I think where we need to coalesce is around prioritizing the action steps. So prioritizing what we know works. I mean, there's ample evidence about the impact of social determinants of health and the potential benefits of upstream investments that positively impact health outcomes for populations of people. We need to coalesce around committing to implement those long-term strategies. These are not going to be 1 year, 2 year, 3 year, even 5 year kind of grant cycle solutions, but we need to commit to investing where we know there's evidence, committing for the long term, investing at scale. We're in a unique situation right now where there's money being thrown at problems. The challenge is how to spend that money. We need to be committed to strategies that have reason to believe that they'd be successful, invest in them for the long term, and then also remove those distractions and barriers that get in the way of us making progress. Distractions like, reimbursement rates for critical roles in our system. We know that we need to reimburse people at pay that creates living wages and supports households. We know that we need to reimburse for certain critical roles in our system. We know that we need to invest in education and housing. We need to secure basic needs in order to then advance conversations around other opportunities to help people thrive. We need to not be distracted and spend time fussing over if we should or shouldn't do the things that we know are proven effective and are necessary for all folks to thrive. And then be committed and coalesce around making the investments for the long term that have been demonstrated to be effective. I'll say, Corey, I'm surrounded in public health by folks who, we all kind of want to save the world and are good intention in doing God's work. And I am surrounded by those folks in healthcare settings as well as in other systems. There's no shortage of good intention. We need at this point to focus. We have acknowledged the problem. We now need to focus and invest in the solutions that we believe will drive us towards success, and be committed to try new things and be committed to serve populations that have traditionally been left behind.
It's a really good point. And you focused on, this isn't a 1 year quick fix. And so you've been in this space for a while. Is there anything over the last decade or so that you've seen really marked improvements in, or maybe even some areas that you look at and say, we really haven't moved the bar enough, we've got to focus there a little bit more?
Sadly, there are more examples of where we haven't moved the bar far enough than those where we've had, in your words, market success. We have seen success in closing some gaps in access to primary care and dental services. There's improvements there that we can continue and must continue to build upon. We have seen some improvements in localizing access to supports in addressing social determinants of health, like food access. Haven't solved for that, but we have seen progress. However, if you look at just public health data, we haven't closed disparities in health status and health outcomes to the degree that we want. We have not, and frankly, we're kind of static, despite all the good intention in the world. We continue to see, and as a result of the pandemic, we're actually seeing some indicators going in the wrong direction. We need to address emotional health and well-being. We need to address access to behavioral health supports. We need to address, as has been said in many venues, louder and louder. We need to address basic needs like housing and food access for everyone. We need to make sure that folks have access to jobs and childcare, and that the workforces that are supporting those jobs and childcare can continue to operate and thrive. If we're going to close gaps in healthcare outcomes. I mean, I know this panel is focused on healthcare, but we have to realize health is housing, health is food, health is childcare and basic needs. These are all impacting health outcomes, and they're impacting the ability of the healthcare sector to function optimally. And there's, again, with focus and long-term commitment and investing in what we know works. And I know that my colleagues and peers on this panel will speak from their perspectives to this as well. You know, there's opportunities that we can cling on and really leap forward as a state.
Completely agree. Dr. Nunn or Dr. Macarthur, is anything you'd want to add to that?
One thing that I would add, just to put a fine point on something Carrie just said, the World Health Organization has actually published some data and information basically saying that 30 to 55% of health outcomes are determined by social determinants of health. And that's not what we usually think of. We generally think of medical problems. Somebody has diabetes, or they smoke, or they have heart disease. There's a variety of things that we think of when we think of health. But when you think that more than half of health outcomes are associated with and are a consequence of social determinants of health, it just tells us those are the things we have to spend time on. They're the first things you have to address before you deal with acute conditions.
I'll just add that I agree with everything that's already been said. I think the one thing that is worth noting is our dramatic and remarkable insurance coverage rates in the state of Rhode Island resulting from the Affordable Care Act. Our state expanded Medicaid early and aggressively, and it really was the public health triumph of the last decade for our state. I am originally from Arkansas, and I still work some in the Deep South, and our patients in the South do not have the same access to health services that people in Rhode Island have. Our system is far from perfect, but the expansion early has really allowed us to make a big dent in our big advances in promoting more equitable access to health services. We still have alarming challenges with our woefully low reimbursement rates that Carrie alluded to. I think our reimbursement rates for Medicaid are about 30% of what they are in our neighboring states. There are bills before the House and the Senate that would try to close those gaps that aren't even focused on getting to that 100% of the Massachusetts rate, but are trying to get us to about 60% of where our neighbors are. That could provide real opportunity to narrow a lot of the gaps, because what happens is if health systems lose money on Medicaid, it ends up having very detrimental impacts on people of color, because they start declining to see Medicaid patients, or they close the door in indirect ways. And so we've got to get our reimbursement rates higher and on par with those of the surrounding states in order to keep building on our success from the expansion of the Affordable Care Act. We have insurance rates, I think we're number 2 or 3 in the nation, which is nothing to scoff at in terms of our insurance rate coverage. It's remarkable. I think we are second only to Vermont and Massachusetts, but if we can get our reimbursement rates up, we'll be able to build on that success.
Great points by everyone. And I want to take us back a little bit, take a step back and talk a little bit about the Rhode Island Public Health Institute. Dr. Nunn, can you give us a start by just talking about the Rhode Island Public Health Institute and some of the things that you're working on there?
Yeah, so our mission is to reduce health disparities in Rhode Island and beyond. And we have public health programs, research projects, and advocacy campaigns that address the social determinants of health. The common denominator across all of our programs is we are addressing social determinants of health with public health innovation. Most of that is usually by offering culturally tailored services, or programs that respond to the social determinants of health. We own and operate the state's only LGBTQ clinic. That's one example of a culturally tailored service. And we also offer several different food insecurity programs. One is called Food on the Move, which is I believe the nation's largest mobile produce market.
And that's, I've seen that firsthand and very impressive. And, you know, a lot of the work you're doing at the Rhode Island Public Health Institute, and Carrie, you're doing at Lifespan, seem to serve a proof of concept as you're thinking through how do we create new access to things that perhaps were gaps in the system itself. And your Food on the Move program that you referenced is proving that if you're able to bring healthy food to individuals that may not have access to it, they will utilize it and they will be able to eat healthier. Open Door Health is really providing patients that traditionally were underserved and creating that access point, proving out that if you provide that access point, people will show up and people will come. And what needs to happen to really make these programs scalable in a much broader way across the state of Rhode Island and across the country?
Well, I've alluded to the importance of increasing Medicaid reimbursement rates. The other thing I'll mention for our food work is we know that the single biggest barriers to eating, first of all, food-related chronic disease accounts for the overwhelming majority of the growth in our healthcare expenditure, along with comorbid mental health conditions. And in order to address that, we've got to get people eating healthier to reduce our spend on metabolic syndrome, diabetes, and all the other consequences of poor diet and heart disease. And in order to get people to eat healthier, we have to address the social determinants of health. Our research has shown that the biggest barriers to healthy eating are access and affordability of fresh fruits and vegetables. We have found that with our mobile market, that when we bring people fresh produce to public housing, that people, and offer it at subsidized rates, that people eat healthier. So we have a program that's supported by some of our corporate sponsors, as well as the U.S. Department of Agriculture, that doubles the value of the dollar when people buy fresh produce. That means $1 is worth $2 when people shop with their EBT cards or their SNAP cards. And we have found it has been associated with dramatic improvements in healthy eating behaviors. We're proposing bringing a program like that into retail settings to address a lot of the barriers to eating healthier foods. We know that people want to eat healthy. It's just that a lot of people have trouble affording fruits and vegetables, particularly during this time of dramatic inflation. And so we think that this is a program worth investing in, to Carrie's point, across the entire state for all SNAP recipients.
Yeah, and you make a good point. As the inflation comes through, this is only going to become a bigger challenge, a bigger problem across the state and across the country. I want to
Corey, can I add?
Yeah.
I'm sorry to interrupt. Can I add to Amy's excellent examples of the work that the Public Health Institute is doing, and just they're demonstrating the opportunity and the value of those services in community settings. We're in the middle right now of doing community health needs assessments with each of our hospitals. And I was lucky enough to participate in one of our community forums last night at an elementary school in Providence, and have a number of parents participate and, come have dinner with us and tell us about their health concerns and what they'd like to see our hospitals do to address their concerns. And something that was shared last night that is a theme across these forums, and frankly, it's been a theme in past iterations of community health needs assessments back in 2016, 2019, and again this year. For all the work that we all do, every one of us that's represented on this webinar today, to advertise our services and programs and to deliver innovative programs, we still need to continue to help folks with access in the most fundamental of ways, access in the right languages, access at the right times and locations, access in terms of helping people get transportation there. One woman who participated last night described she has 3 kids. And she has one child who has had some behavioral health emergencies. And imagine she's trying to respond to that emergency and get her child to a care provider with her other two children in tow. She doesn't have a vehicle, taking a bus, making multiple exchanges, only to get to, let's say, an emergency department where she sits and waits for a number of hours with three children, and is told, well, you're going to have to come back and make an appointment with another provider, and do it all over again, potentially multiple times. Or get to a primary care provider's office and have them say, oh, well, you need these three other appointments to get a comprehensive assessment of what's going on. And every appointment is a physical challenge to get there with her kids, for her to take time off of work, for her to, pay for the visits, all of it. And I think it can become very easy for us to set up programs and services and systems that work for us as providers, but that don't actually work for the patients or people that we're trying to serve. And so I would also just remind us not to forget the basics of, we need to double down on providing what I call hyper-local access to services, hyper-local education and outreach, hyper-local screening services, assistance with transportation. And there are all kinds of novel things being done, with not just MTM for folks who have the Medicaid benefit of transportation access in Rhode Island, but also, Uber and Lyft and other transportation, and more needs to happen to help people get to appointments. Acknowledging that folks live real world lives and they need to provide childcare for other kids while they get to an appointment, and can't take time out of work time and again and keep a job in order to, get an assessment completed. And so the examples like Food on the Move and bringing food and produce directly out to housing sites is exactly the type of work we need to be doing. And we need to amplify that and make sure that we're bringing services out to folks' communities, hyper local, to the places where they live, to the places where they work, delivered at times that are convenient to them, in their language, accessible through, different dimensions of accessibility. And these are things that we know, and then we can design these sophisticated, phenomenal programs and forget the fundamentals. And I just would remind all of us that the fundamentals still matter, and frankly matter more in this time of insecurity and increasing inflation and other challenges that families are experiencing.
Completely agree. It's execution against the fundamentals, and wanted to open that back up because I actually think that's a great point as we think about design of a future state system, where we need to meet our patients at in order for them to really be able to access what we're talking about. Dr. Nunn, Dr. Macarthur, anything you want to add?
Yeah, let me sort of take a stab at what my sort of general feeling about this. For whatever reason, healthcare in the United States, in Rhode Island, everywhere, revolves around what happens in an acute care setting. And there's nothing bad with, we need state-of-the-art acute care settings. We need to be able to provide people acute treatment when necessary. But that's not what drives healthcare. Healthcare needs to be community-based. As Carrie mentioned over and over again in her last comment, it's meeting people in the community. It's really with a focus on, yes, you can treat people in the community, in their community, but you can also prevent things a lot better and not have this. We have to change the focus of the system where it's not about acute care and everything being around the acute care setting, but rather everything being in the community. And we have all the supporting things around the community folks, acute care being one of those items. And that's going to change. That will fundamentally change. If we can, as a society, accept that notion, it will change our ability to impact inequities in healthcare. Because if you have someone who has, stigma around their particular medical condition, or they look differently than the people who work in the emergency department, or they don't have housing, they don't have transportation, all those things aren't getting addressed in an acute care setting. Yes, they're trying, there's social workers, there are people trying to do things, but that's not where that needs to be addressed. It needs to be addressed ahead of time and in the community. And we need to rally all of our resources, everybody who's focused in healthcare, and trying to get people what they need in the community, in their homes, within their general perspective of how the world works, as opposed to trying to make them integrate into this acute care setting model that we have.
Great points. And just a reminder for the audience, if you're listening and you have questions, please feel free to drop those in the Q&A box and we'll do our best to try to get to those. Moving on, I want to flip the conversation to Dr. Macarthur, who is Chief Medical Officer at CCA. Dr. Macarthur, I'm curious to hear your perspective from our shared point of view at CCA. Can you talk about the role insurers and providers can play in this effort? And what specifically is CCA doing within its own organization for its members?
Yeah, there's a lot we can do. The number one thing we can do is acknowledge it's our responsibility to address these problems. So we have a role in this to address the problems. I think most people view payers, particularly for-profit payers, as purely financial entities, transactional, providing financial support. There are many good things that are associated with what a payer does, but a not-for-profit organization, not-for-profit payer, has the opportunity to do the long-term look at what's happening. If we address the social issues and we own it, we help address issues of poverty and income issues, the unequal access to healthcare, the lack of education, food insecurity, as has been mentioned several times on here, housing, recognition of historic trauma that people have. If we invest in helping people address those things, then they're going to have a lot better chance at successfully achieving wellness and health. So that's, to me, is really key. You have to commit to it. So an organization like ours, the vast majority of our members who enroll in our plan are assigned to a community health worker who really works with them to address it. It's not that we pay for lots of things. Health plan, you want to be able to do, you want to have expanded benefits. You want to be able to say, if I pay for this now, I'm going to save something significantly down the road. You got to be willing to do that. Historically, many payers would say, not my problem. I'm responsible for their hospitalization, for the medication for their diabetes, et cetera. Not thinking about, okay, how do we keep that from actually happening in the long run? So we need to invest in that first. How do we help solve those problems? So I think it's critically important. And the other part of it's really around behavioral health. I know that's not the focus of this, but a lot of inequities in healthcare are driven by people with behavioral health issues. They're very prevalent in the community. It affects their ability to access healthcare successfully. And we really need to kind of take ownership of that, not just kind of give lip service to it, but we really need to own that. So it's all about owning it, putting your money where your mouth is, getting the resources out there, training the resources. And the other part that's incredibly important, it's also incredibly painful sometimes, is working with the community resources and the advocates. So everybody who advocates for people who really have challenges in life, we need to listen to those folks. We need to listen to the members. They're the ones that are going to help us. From where I sit, white, middle class, well-educated, my experience in life is fundamentally different from a Haitian immigrant who comes to the United States who doesn't speak English and who's having significant problems. So, how am I to fully understand the mind of those individuals? So we really have to invest in that. We have to hire people who look like the people that we're here to serve, who understand that. We have to train our staff to be have some cultural intelligence. I don't think you hear the word cultural competence. I don't think anybody can be fully culturally competent unless you've been in somebody else's shoes. And most of us can only be in the shoes that we're in. So, but we can be informed of, what are some important things to know? How do we help people get access? Acknowledge the challenges that people are having. It's really, truly about the commitment and coming up with some very specific solutions. A little bit, I'll probably, share some of those things with you.
And we actually had a good question come in, Rob, as you were, Dr. Macarthur, as you were coming in around community health workers, and how is success measured with the community health worker role?
So it is a good question. Obviously, it's it's difficult to put performance measures in other than saying you have so many contacts with individuals. Success is if somebody needs housing, are you helping them secure housing? Are you connecting them with the right community resources? And are you following up on it? That's what success is. It's not just sort of you go meet somebody, you talk to them, oh, here's a list of people you can go to. That's not what success is. Success is being there, being a partner with them, walking through the walk with them, helping them stay there, and then following up on it after the fact. So every 30, 60, 90 days, whatever is necessary in individual circumstances, that's what success is. Getting food on the table, connecting with community-based resources that have food, or, you know, providing medically tailored meals if that's necessary. The health plan can pay for, you know, those things. It's actually taking ownership of getting the outcome for the individual.
It's great. And one of CCA's primary goals is ensure our members have access to the healthcare system's many front doors, Dr. Macarthur.
Mhm.
Can you talk about how COVID really has changed the whole way in which things like telehealth, in-home visits, and community visits have become a part and core to now how service is delivered to individuals? Is it purely just COVID induced, or is this going to be part of how we deliver services moving forward?
Yeah, both. I think. I mean, as evidenced by the fact of what we're doing right now, we're on a virtual presentation. The whole world has moved to incorporate that into our routine. It's not our only routine. You know, we can't connect people. I can't assess somebody as a physician through, you know, fully by looking at them, but it helps. Just visualizing somebody does help. It's significantly better. You know, one of the things that CCA did from the beginning, fortunately, we were planning on really investing in this before the pandemic hit. So we had a little bit of we had a framework, we had a plan. And of course, the urgency hit when the pandemic hit and the whole world sort of shut down. People's lives continue. So we had to continue to provide some support and some access to individuals. So we did several things, recognizing that many, you know, there are some of us, like probably all of us on the screen right now, we have access to devices. You know, we know how to use them. We have reliable services that support our devices, internet, Wi-Fi, whatever. We have that. You can't take that you can't take that for granted, certainly for folks who have challenges. And the reality is that could make healthcare disparities much worse. If we all move to this sort of virtual world, or it's the support structure, if folks don't have that, then they're never gonna, you know, you're just building another barrier in the system. So one of the things that we did up front is, you know, I talked about, to me, this is really one of those social determinants. How do you, if you don't have access to communication, you know, in the modern way, then you've got another barrier. So we've worked hard to connect people with devices. We've paid for some, we've done lots of pilots. We connect them to federal resources that supply people phones. There's a whole suite of things that you can do. Not that you can solve everybody's problem, but you want to be able to do that. Number two, you want to make sure that they have broadband or internet access for everybody, because if you don't have it, your device is useless. And, you know, the third thing, which is equally important, all of us have experienced this, is this thing's not working. You know, I need an IT support. So understanding that our members or folks in the community, particularly those who are challenged to successfully engage in healthcare, it's even harder for them to figure out how to use this. And, you know, we want to make sure we have provided our members with access to those kinds of support services, so they can call a help desk basically and say, I'm having a problem here. I mean, this is one example of how the pandemic has changed, or I would say accelerated. I mean, video technology has been around for a while. Remote patient monitoring, where you can actually monitor things routinely that are medical things, is extremely important. And, you know, as a health plan, as a payer, we need to support that kind of activities and connect providers with members, helping those access points work well through all the technologies. Going back to a point I made earlier, and you talked about in-home visits, community visits. I, to my deepest core, believe that healthcare needs to be centered around people in the community. Otherwise, we are treating illnesses in an acute care setting. So the pandemic has heightened for some people the need to, because they couldn't or fearful of going into acute care settings, a doctor's office, many of those weren't available. Go to the emergency room, many people were terrified that they were going to get sick. It's, you know, those things are very real. So we go to them. We've got to find a way we can do something that's economically feasible. I think going to offices is fine, but the core and center around someone's health really needs to be based in the community, in their place of where they choose to live, and supporting them there. And then use the other acute care or subacute care things as is necessary.
Really, really great point. And so for some of the audience who may not be as familiar with CCA, CCA really has a reputation for being committed to social needs as much as the clinical needs of our members and patients. What are some of the innovative programs, Dr. Macarthur, that your team's currently working on in CCA more broadly?
Yeah, I think there's a lot. Some things are simple and low tech. And the first one I'm going to say is thinking about respecting people's choices and having that as a part of our culture. So every clinician who works for the organization, every person who interacts with someone, regardless of where they are in the organization, really respects the dignity of individuals and the choices that they have made, and not to be judgmental. It's incredibly important. You're going to have an immediate barrier if you don't do that. It's hard to do, but you need to do it. And it's, to me, it's one of those critical things. It's part of the culture. When I came to CCA 4 years ago, it was one of the first things somebody said to me was, we respect the dignity of risk. And I'm like, what is dignity of risk? I mean, I didn't even really understand the concept really until somebody explained to me, and I was like, oh, that makes sense. I just hadn't heard that particular phrase before, but it's core to what we do. So that's very low tech, doesn't require any sophistication, but it's a cultural shift. And this is pervasive in healthcare. We tend to be kind of judgy. Why did you do this? Why did you let this go so far? How come you didn't ask for help before? Can't do that. We're in the here and we're in the now, and we need to help people. We need to answer their questions. So, I mean, that's one thing. I'm going to take it to the opposite extreme. So that also will, that I would say is a little bit scary, is using data, informatics, artificial intelligence to help guide. We have a wealth of information today. And if used safely, if used with many safeguards, we can really help clinicians, guide clinicians to immediate risk, because there's lots of social data out there that can point to that are real-time information that's coming in, that something's about to happen. Somebody's at risk of losing their residency. They're at risk of being evicted. We have ways to monitor that without having to get a phone call from somebody. Certainly when somebody shows up in an emergency room or an urgent care, you can reach out and connect with them. So building all these things together, using all that data in a very safe way, so it's not shared with everybody, but in a way that highlight to either a health plan care partner or a provider who's seeing someone in the community, hey, here's something going on. This is real time. This is today. Reach out and connect with this individual. And I think it's something we put in place in the pandemic. It was incredibly successful. We monitored every patient every single day. So this sort of, as the guy who developed an organization called the machine overnight was constantly sort of churning out this data. And it was very helpful. And we stayed really on top of what was going on with individuals. It's not 100%, nothing's 100%. But, to me, that was one of the things that, is an innovation that we use in the organization. And I'll give one more, and then I'll stop, because there's a long list. We're a very innovative organization. Is that we really focus on integrating care. So what does integrated care mean? And basically, you take the different pieces of this healthcare system and make sure that they're connected, so that people are communicating back and forth. It's very fractured and very siloed. And I'm not saying we've solved this problem, because we haven't, but we're trying to come up with ways to integrate things. One of the things we're doing now is we are implementing something called an engagement center. An engagement center is an area that's actually physically attached to a primary care practice, where you can have social workers or legal support or housing support, or wash your clothes or get a snack, or have meetings with people who have similar circumstances to you, places where you can support individuals. This is fully funded by the health plan. These are things that we recognize, if we can help somebody to address their social needs, whether it's loneliness or helping them secure housing. They may not want you to come into their home. A lot of folks don't want you to. We believe that we learn a lot when we go to somebody's home, but we also respect, their right to privacy and their dignity. So it's an alternative resource. It's a place for us to address their social needs.
Those are great. And we actually, while you were speaking, Dr. Macarthur, we had a question come in from the panel, which Carrie and Dr. Nunn, I'll let you to take this one. So has Rhode Island experienced a shortage of providers across the system in all specialties? We keep hearing about too few mental health providers across the country. And how does that present Rhode Island? And how does this impact access, particularly for low-income folks?
Yes, I mean, I can tell you from the health system, we have a lot of openings. If you're interested in working in healthcare and in lifespan, where every role imaginable exists, we're like a small city, please visit our website, lifespan.org. We're hiring. But I'm a little bit tongue in cheek, but not, I am serious. We are hiring. We have a lot of openings. Yes, the provider shortage exists in Rhode Island, just as we're hearing about it nationally. It is particularly acute in behavioral health care. It's particularly acute. In fact, Lifespan put out some information within the last week about the experience of children with behavioral health needs having limited access to providers because there's not enough providers, and ending up in hospitals and inpatient beds and basically boarding in our hospitals for want of the more appropriate treatment location and modality. It is a real issue. It is approaching crisis level. And Dr. Dunn spoke about reimbursement rates. That is an impact not just at the more entry-level positions, but also at the more specialized positions. Providers who could work 20 miles to the west or 20 miles to the east and make a lot more money. You got to have a really strong reason to stay in Rhode Island and work here when you have the option to do the same work elsewhere for more. And that contributes. The experience of working in healthcare over these last couple years has just been, grueling. And people are exercising their options to work in a different setting. And so, yes, we are experiencing the provider shortage. And I'll just use that to reinforce something that Dr. Macarthur said, a theme that was coming out of his comments. Healthcare and health more broadly, this is about human interaction. This is about acknowledging other people, acknowledging their existence, acknowledging their autonomy, acknowledging their needs, showing respect for them. And I say all the time, I work in a service profession. I might not have the golden arches on my shirt, but I'm in a service role, and approaching it with that mindset and the value of wanting to serve and provide respectful care. Because even though I'm not a clinical person, I believe, we're providing care to folks, especially when they are at a really difficult time in their life, when they're not feeling well or when they're experiencing some kind of crisis or emergency. And so all of the workforces that support healthcare, including community health workers, as was, specifically asked about earlier, they're all incredibly valuable. And part of what they do is help to avoid further crises. And so, to the question of how do you measure their success or effectiveness, it's everything that Dr. Macarthur said, but it's also that impossible measure of the crises that were averted. And the value of walking side by side with someone and helping them navigate and helping them build their own capacity to navigate these complicated systems we've set up for healthcare and for insurance and for housing and all of that, that value is priceless. And we need to reflect that in our hiring, as Dr. Macarthur said, to represent the communities we serve, in our advancement opportunities, in our reimbursement rates, all of that. But this is a human, for all the good of telehealth and the tools that, electronic and technical tools that we should continue to develop and improve access to, those are needed, but they don't replace that. We have to value that human interaction and support humans to serve and work with other humans.
Great. And Dr. Nunn, did you want to follow up on that?
Sure. I'll start by saying I agree with everything that Carrie said, and just it's hard to overstate the personnel crisis. It is extremely complex, but I also want to note that it is affecting our clinical leadership. Let's take stock on who has resigned in the last couple of months. The CEO of Care New England, the CEO of Lifespan, the CEO of the Rhode Island Foundation, the director of the Department of Health. So this personnel crisis is affecting clinical leadership and leadership in philanthropy. There is all of this is having ripple effects all the way up the leadership ladder, and we really have to have a federal response to reimbursement, but we also have to have a state response. Reimbursement is a shared responsibility between the state and the federal government, and we really need to have policy members to get their attention about how grave the personnel crisis is. I know it affects our clinical operations every day, and what happens is that most people that are, it compounds on itself, and most people that are left, including people at the bottom of the wage of the earning of the healthcare wage ladder, middle managers, all the way up to leadership. Everyone who is left is now doing 2 to 3 jobs, or twice as much as they did before, because there simply are not enough people to help, and that has exhausted everyone, including the leadership, because everyone has to do more with less. And it's time for us to take action politically from a policy perspective to address this crisis.
Great. And COVID certainly has had that impact and many negative impacts. One positive that COVID really brought forward was a lot of collaboration between the healthcare system as a whole and community partners. And that's something that really was allowed for different delivery of services to individuals in a way in which they really needed it. In all of your opinion, this would be for the entire panel, is there enough collaboration going on today amongst the players in Rhode Island? And does there need to be more?
You know, I don't want to be all doom and gloom. I think that this is something we do pretty well. All of us know each other and already work together. Whatever one's perspective is on the mega merger, all of that aside, I think that in general, we have pretty good collaborations, and there's been a great collaboration from the Health Equity Zones Initiative, the Department of Health, to the clinical, Care Transformation Collaborative that's working on value-based care. I think the last piece of the third leg of the pedestal is the social determinants of health. And we've got to all be rowing in the same direction. To Carrie's earlier point on some of these big issues, we've got to come together and bring the payers to the table to talk about how housing can impact health, and behavior change related to healthy eating. Some of the big things that are driving the disparities have to be addressed, and we've got to pay clinical providers, but also non-clinical providers have to be brought into the fold to make this an economically sustainable model.
Yeah, I agree with Amy. In my experience, there's a high degree of collaboration within healthcare. What I'm excited about, and I think the one positive effect of the pandemic, is it's kind of propelled us forward maybe a little bit further, a little bit faster, and I'm excited to capitalize on it, is the collaboration between sectors. And so I'm seeing more collaboration between healthcare and social services and housing and food programs, and that's the kind of work that I'm excited about continuing and, frankly, increasing the momentum on.
Great. And so as we think about this year in Rhode Island is an election year, and certainly not to make this political, but as we think about that, there are obviously a lot of discussions, debates, and points of view that are being put forward on various topics impacting the state of Rhode Island. Certainly one of the major ones is health. And as we think about that, do we think enough attention is really being given to the issue of health equity? Open for the entire panel.
Well,
I was just pausing to reflect on it. You know, I think that these things have been in the headlines more than ever. So I think there's opportunity to build momentum. And I was just pausing because I was thinking about all of the proposals that are on the table. We're the last state to spend our ARPA dollars. The hospitals have a $200 million ask in. There's a $500 million ask in for ARPA dollars for housing. And the state is probably going to make a huge commitment to housing for the first time in many, many years. So I think we're doing pretty well. I think the fact that we're here today having this conversation, we need to have more of these types of conversations. But I think that the people that are running for office are paying attention and focusing on these things. I think a lot of people have COVID fatigue. We all have COVID fatigue, but the virus isn't done with us yet, and it pops up and affects health disparities in remarkable ways. And so we've got to keep paying attention to that, even if we're tired. But I feel optimistic that there's going to be some movement on the social determinants of health this cycle.
Yeah, I'll say I'm greedy. And, as a public health professional, as we've talked about already in this conversation, health is connected to every significant issue of concern in Rhode Island. Health is connected to housing, health is connected to emotional well-being, health is connected to food security, to equitable access to high quality healthcare services. And so, in this election cycle, I'd like to see every elected official or prospective elected official describing the centrality of health to anchor their conversations about thriving communities and about building a thriving economy in Rhode Island and a thriving business sector in Rhode Island. And, I'd like to see the references to health woven through all of the strategic goals of our candidates and elected officials in Rhode Island.
Great.
I think if you think back, you guys may agree with me or not, but when I think back to 10 years ago, as recently as 10 years ago, there were certainly advocates and people out there who were talking about social determinants of health, but rarely did I hear it on any kind of statewide or national forum. Boutique things that happened, people talked about it. There were people who were invested in it, certainly people who worked with lower income populations, but not on the scale that we hear about it today. So there have been, it's rare to go to a conference. It's rare to go to a meeting where somebody isn't talking about it. So it's made its way to the public stage. Now people have to believe that it is as important as we know it is. And they have to take some ownership. No matter where you're a politician, whether you're a hospital organization, whether you're a provider organization, whether you're a payer, a support agency, a community-based organization, we all own it. We all have parts to it. And I think we have to take that commitment and recognize health is not picking up your metformin for your diabetes. Health is making sure that you're getting an adequate diet, that you understand the need to keep your weight in a healthy way, understand your risk of developing diabetes, and then supporting you if you do get it, supporting you in your home and your community. That's what health is, and that's what social issues are really, really all about. It's not about having your medication for your diabetes.
Yeah, well said. And so we're getting close to wrapping up. So I want to end with a little rapid fire here. So for each of you, I'll start on my left, which will be Carrie first. In a minute or less, what's a reasonable goal related to this issue that you and your organization are hoping to accomplish over the next 2 to 3 years?
Yeah, I don't know how reasonable it is. I said I'm greedy. I'm also aiming high. But I'm excited to see my organization, Lifespan, continue on the path that we're on of engaging more with community partners, engaging more across sectors, to bring the expertise of our system out into community settings, to bring the resources that we have available out into community settings, making it available to populations, and working to address some of these social determinants of health and get upstream. We're doing great work with screening patients for health-related social needs and providing navigation support and community health workers. And I'm excited to see that work grow to serve more of our patients. But I'm equally excited to see that work grow so that the expertise in the community is channeled back into our system to inform and improve our lines of service, because it's really bi-directional. And so that's what I'm most excited about, is to just see that work that's already in flight just continue to grow, and it benefit the communities at a local, hyper local level, and it benefit our system in improving our services to respond to the actual current and needs of all of the populations that we serve.
Great. And Dr. Nunn, you're next.
So we have a bill that is working its way through the legislature that would double the value of SNAP when people buy fresh fruits and vegetables at grocery stores. It's taking what we know works from our mobile market and bringing it into retail settings to the 144,000 people who use SNAP in our state. We know that this would enhance people's healthy eating behaviors and people at the lowest end of the wage spectrum. So we really have laser-like focus on this policy initiative this session, and we also want to help evaluate that pilot project.
Excellent. And Dr. Macarthur.
I'm going to sort of take a riff on one of the previous conversations that Carrie and Dr. Nunn talked about, is this issue of behavioral health. And this was, I guess one of the folks asked the question. I think that's a challenge. There are many things we need to focus on. I don't see a short-term comprehensive solution to addressing the access to behavioral health providers. I think it's how do we triage, how do we tier, how do we support individuals? And I think a realistic approach for us as an organization is, so we sort of think of this sort of escalating line of having a community health worker who's not a behavioral health specialist, but they're not also a clinician, but they can understand if somebody needs the support of a social worker or a LICSW, or they need to get involved with a therapist or advanced practice clinician, or are we going to get them connected to community resources around their sort of cultural identity to help them with this, or get them to the psychiatrist. It's this sort of tiering approach, but taking ownership to getting it through, because we're not going to have enough psychiatrists. We're not going to have enough therapists in the near term. There just aren't enough. There aren't enough in the country. We never had them. And so certainly the crisis has been made much worse in recent years. It's a critical part of addressing people who have unequal access and unequal outcomes from healthcare services. So we have to address it. So we have to kind of take ownership for that all the way through. And one of the other things sort of at the end that I would say that we could add on, that we could and should add on, or something, the notion of a crisis stabilization unit, which is a physical facility where that people can freely come and go, but they generally stay for a period of treatment. It's not the same as an acute psychiatric hospitalization. They can get therapy, support, food, housing, whatever needs to be there until they're safe to go back to the community and get outpatient work. So it's that long continuum, but we have to stay committed and focused. Okay, this crisis isn't going away. How do we use the resources we have to support these individuals?
Great. Carrie, Dr. Nunn, Dr. Macarthur, thank you all so much for giving us a lot to think about today. We covered quite a bit throughout the course of the hour. We're just about out of time, so I'm going to invite Courtney back up on the screen to wrap us up.
Yes, thank you, Corey. Thank you to Corey McCarty. Thank you to Carrie Bridges-Felice, Dr. Amy Nunn, Dr. Macarthur. That was fantastic, really. And thank you to the Boston Globe for providing us the platform to have the discussion. Also, thank you to everybody that joined us today. You can learn more about CCA Rhode Island online at our website, commonwealthcarealliance.org/RI. And if you have any questions about us or what we're doing, we'd love to hear from you. We will include the contact information of the panelists in the chat or in a follow-up email to all of you who attended. As we continue to grow here in Rhode Island, we really look forward to continuing this important discussion and playing our part in moving the needle toward a more equitable future. Thank you and have a great day.